one of the other really interesting topics at the prostate cancer debate in Madrid has been castration-resistant prostate cancer. And I think the big take-home message is that we're in a little bit of an evidence-free zone for those men who are treated with abiraterone or docetaxel for their hormone-sensitive disease, because it's difficult to know if the other studies still apply. That can we look at those results and now apply them in this setting? And I think we had quite a lively debate, presenting a case of a man who has relapsed after docetaxel and ADT and docetaxel, and then relapses. And what were your thoughts on the sort of audience's opinion on that? So with their ADT and docetaxel.
Well, actually, we try to use common sense in our treatment. There are actually not many news and changes because the treatment are quite established in this scenario. So patients who relapse after having docetaxel, the tendency is to give cabazitaxel, not to re-challenge with docetaxel. Patients that relapse after abiraterone, for instance, they will get docetaxel. They usually are not treated with enzalutamide because the results are not very good, with just a 20–30% response rate. So among all the treatments, we have to keep in mind that radium is there, and we can choose for some patients radium-223, although we have to select the patients adequately, just with bone metastasis, symptomatic in most cases, but also in some countries you can treat patients that are not symptomatic and without visceral disease. So the thing that it came out also in the discussion is that some patients, after several lines, after they fail several lines, some of them don't want any treatment anymore. I mean, they are exhausted, they are in a frail condition, and some of them actually decide not to go on with further treatments. So actually we try to use common sense, and the most important thing in this patient group, I think, is to give them the best quality of life. Because we know that we are not going to cure the patient, so quality of life after the first couple of lines, I think is number one choice and aim in our practice.
And I think that with a lot of the sort of the novel hormone drugs coming through, and certainly with abiraterone and prednisolone, and using that as sort of first line for CRPC, certainly in my group of patients, I think I worry about potential toxicities rather than they report side effects to me. And obviously we need to monitor the very reversible side effects of a low potassium or small risk of abnormalities in liver function and monitor their sort of cardiac status. But I think some of these drugs have been so well tolerated that it has changed completely the way in which we sort of treat patients with CRPC and are able to give sequential therapy. I think one of the questions that came up a few times was about evidence, and I guess until we have prospective studies, something like the St Gallen Consensus can be a good way to start to just sort of look at what experts are sort of doing around the world and how they are sequencing treatment after hormone sensitive.
Sure. I mean, we try to follow guidelines, but sometimes you have to treat outside of the guidelines. So St Gallen Consensus, which was published in European Urology quite recently, is a way to orient yourself and to try to give the patient the best alternative. Yes.
It's quite good actually that the clinical practice is leaping ahead of the evidence and the guidelines, because things are changing so quickly. One of the other things that we discussed quite a lot in my breakout group was how to manage prostate cancer in the elderly. And over the years I've had some sort of dealings with CIOG, the International Society for Geriatric Oncology, and I think I've incorporated their basic principles into my practice hugely, in that treatment should never depend on age, but on comorbidities and patient wishes. And they very, very clearly distinguish 4 groups of patients. And for prostate cancer men, it would be those fit men who should have exactly the same treatment as their younger counterparts. The patients who are vulnerable, who can have comorbidities retreated. And for some men, I think a diagnosis of prostate cancer highlights their hypertension or their early cardiovascular disease, and we can actually treat that and get them to a stage when they can have standard prostate cancer therapy by treating the comorbidities. And then we have the frail men who probably need adapted therapy, and very sadly the ones who wouldn't be suitable for treatment. But we talked quite a lot about how to adapt different therapies to the older population, who I think are going to be more and more of our practice as we go on. Thankfully we live longer.
In my group, the same. I mean, the age was not the limit. It was the comorbidities and the performance status of the patient. So this is probably the most important thing to know if a patient is able to receive more toxic or less toxic treatment. Yes.
So I think that probably concludes our discussion from the Prostate Cancer Debate. My name's Heather Payne. It's been a great pleasure to be with you today, and thank you very much for listening.